Hello, everyone. Welcome to RheumNow's RA Recap. This is a post-meeting review of the great abstracts from EULAR 2023, and this group is going to focus on the rheumatoid arthritis content that was prevalent at the meeting. I'm lucky to be joined by our colleagues who were all at the meeting and all very keenly interested in RA. So we'll do introductions and then get right into it. Hi, I'm Jack Cush with RheumNow in Dallas, Texas. Antoni?
Hello, I'm Antoni Chan. I'm a consultant rheumatologist from London, United Kingdom.
David?
I'm David Liew from Melbourne, Australia.
And John Kay?
And I'm Jonathan Kay from University of Massachusetts, Worcester, UMass Chan Medical School in the United States.
Maybe the most disappointing part of this whole meeting is that John Kay did not have the opportunity to wear a beret or an appropriate headgear for Milan. John, did you search far and wide for something to wear on these recordings?
Well, I looked for one of those Carabinieri hats, but I couldn't find one.
All right, we're going to have to work. I don't know what you wear in San Diego. You know, it's something to do with the zoo or their water park. All right, so let's just get into it. Again, this is a review of rheumatoid arthritis. Dr. Chan, why don't you begin?
Yeah, thank you very much. Therapies were a big area at the EULAR 23 from rheumatoid arthritis. And I think there are a lot of attention to the late-breaking abstract 001, which is the combined JAK1 TYK2 agent called TLL018, which is a study looking at this compound versus Tofacitinib. And in this drug, TLL018, they gave them a dose of 10 milligrams, 20 milligrams, and 30 milligrams versus Tofacitinib 5 milligrams in about 100 patients. In all these studies in the past, the ACR 50 very rarely goes above 50%. In this study, although in the early phase, shows an ACR 20 between 65 to 72% in the people who received 10, 20, or 30. And the DAS28 score in these patients, remission scores were between 39% to 54%. Now, compared to Tofacitinib, the ACR 20 in this study was 41%, and the DAS28 remission was 17%. So quite a significant improvement that we've never seen levels at before, although early studies, small numbers. But this combination JAK1, TYK2 seems promising, certainly something that we should be investigating and looking forward to hear more about.
So Antoni, why do you think A, the results would be that high, or B, why they got numbers that no one else has ever gotten? I mean, is there a mechanism here as to why it might be that high, or design issue?
Possibly the mechanism, having a combination like this with the TYK2 in addition to the JAK1, we don't know. We've not had this form of mode of action. We've had pan-JAKs, we've had selective JAKs, but this is the JAK1 TYK2. Secondly, small numbers at the moment, 101 patients. And then selection of patients as well could influence the readings that we're seeing here. But I would say looks promising, but early days.
So David, you were there and described for me the other day that a little bit of pandemonium broke out about this. Describe what you saw and what your thoughts on this were.
Well, I was sitting at the back left-hand corner of the room, as is my wont often, and I could see just some murmurs wave through the crowd. Everyone was every time a new slide would come up, the cameras would go up, and then obviously there were some very cutting questions during the question and answer section. So I think that those kind of numbers are provocative. Those, I think, no one was expecting that kind of quality of result. That kind of result to come through. I guess the quality we'll find out in due course. I think a lot of us want to look at the paper. I mean, I think you've got to navigate this idea that yes, maybe this has been done. This is a study that has been done in China. I think that we'd like to see some of the results that do come through. I think there had been some interesting things about the patient population that had been discussed at the time, but none of them had been on concomitant steroids. I think we found that a little bit hard to believe from our kind of paradigm. So a few things that may have been a little bit different, but if those results really are true, and I think it's entirely possible that they are, then this is really potentially a breakthrough moment. And we'll see how this goes. Of course, the question will be about safety. We've had some great reassurance from Tofacitinib, the TYK2 inhibitor, and so I guess as long as we're not expecting the synergistic benefit from JAK1 TYK2 to lead to other safety issues, then potentially this is something which is a real winner. But the devil's in the detail.
Yeah, John, what did you think of this?
I had to leave a day early, but it's quite impressive. TYK2 is perhaps a safer. TYK2 inhibitors seem to have a better safety profile than some of the JAK inhibitors. So with these numbers, this is a very promising agent. We need to see more data and subsequent study.
If you really want to get a trial that gets, uber superior ACR 50s, the trial is going to be an early RA, uncontrolled open label, relatively naive patients who've never seen a drug before. This is exactly not the trial they did. They said these were difficult to treat RA patients, all of whom had been on a biologic DMARD or more than one, and they were established disease. And it's a head scratcher. And my only thought is that on one hand, the TLL 018 drug looked so good as far as numbers, but the TOFA numbers look kind of bad. Like the TOFA ACR 50 was 35%, and the remission rate was 17%, something like that. They almost looked like it underperformed. But so there's so much about this that makes me wonder. But as David said, if this is true, and we'll know when it gets to publication and we see all the data, I think that this could in some way change maybe RA therapies, or maybe how we use JAKs. Current JAKs always have mostly this and a little bit of that when it comes to whether it's JAK1 specific or not. This one is strongly JAK1 and TYK2 inhibitory, and so it is different mechanistically. But again, no one had a great answer either at the podium or at the microphone. And Antoni, you get final say on this.
Again, yeah, I think very exciting if it's true that they can treat such late stage, difficult to treat patients with this mode of action. I think certainly promising because we've not seen this combination before.
Yeah. David, what do you have?
I really just want to talk about the recombinant zoster vaccine, because I think those data really are important. I've written about this, but I wanted to address it in this panel and get your thoughts, especially as we talk a bit about JAK inhibitor safety, because there's a lot about JAK inhibitor safety at this meeting. And when we start talking about abstracts like the last one, then of course safety is what comes to mind. One of the safety signals which is undisputed is that of herpes zoster, of herpes zoster in patients on JAK inhibitors. And so this study is actually from the open label extension from Select Compare, which is one of the phase 3 studies with updacitinib versus placebo in patients on stable methotrexate. So in this open label study, they gave patients 2 doses of Shingrix, the recombinant zoster vaccine, at 0 weeks and at 0 weeks and at 12 weeks, and then looked at their immunogenic response after that. So both in terms of humoral immunogenicity and then cellular immunogenicity as well. And while we didn't see the kind of levels that we'd necessarily expect to see in immunocompetent individuals, certainly we saw some very reassuring results. 85% of patients met the mark in terms of humoral immunogenicity. They actually came up with fairly decent going titers. Didn't matter if they had steroids or not, concomitant steroids or not, they still mounted a response. And actually in the proportion of patients where they looked for cellular response, they saw that as well. So I think this is really important because firstly, we know our patients are at risk of zoster to start with. The medicines that we give them are often increase their risk of zoster. And certainly steroids and JAK inhibitors are amongst those as well. We know as well that we can't, in the places where we have other zoster vaccines, we can't give them those zoster vaccines, things like Zostavax, because they're relatively contraindicated, and there have been some safety concerns about that as well. But at the same time, we need to protect our patients in some sort of way. The final thing I'll say is that there were only two flares of RA in this study. And I think that's really telling. We'd seen some data previously suggesting that maybe as many as 1 in 3 patients would flare with Shingrix administration because of the reactogenic adjuvant. But that's not what we saw in this study. And maybe that's because the upadacitinib and methotrexate continued right throughout. So that tells us that we can gain a decent response despite not withholding upadacitinib nor methotrexate when we vaccinate with Shingrix. And at the same time, if we do that, we minimize the risk of flares.
Hey, John, what did you think of this?
I think this is a reassuring abstract. It's important to remember that we want to vaccinate our patients as early as possible. So we shouldn't be in the position of having to wait until they're on upadacitinib to give them a zoster vaccine. But if we do, these numbers look quite good, 85% reactivity to the vaccine. Those are good numbers. So it helps to contribute to the safety profile of upadacitinib. Is JAK1 selective inhibition better than JAK1/2 or JAK3 in terms of immunogenicity of a vaccine? I'd like to know a little bit more about the mechanism to understand this better.
Yeah, they're not having a control that really hurt them. And just David was right in that this was at this stage it was only people on upadacitinib, but the select compare at the outset was upadacitinib versus adalimumab. They completed the trial, and then the upadacitinib patients went forward, and those were, and so they were already upadacitinib experienced and actually largely controlled. So they had stable disease, and then they were vaccinated, and these numbers are what we're quoting. Antoni, in the UK, you have a number of JAKs available to you, and do you use this recombinant vaccine, and does these results kind of mirror what you see?
So it's become available now, being a non-live vaccine. And the nice thing in this study is that you don't have to stop the drug for us to administer it. I think the challenge here is all of these patients were on methotrexate in this study, and we wonder whether if you stop the methotrexate maybe 2 weeks before the vaccine, whether the rates of seroconversion would be higher. But it wasn't done in this study. But nevertheless, it's a nice thing not to have to stop people's therapy while you give this vaccine. In the past, we would have used the Zostavax, which meant stopping the treatment for a period of time for them to have this. So this is a much better approach. Yeah.
The big bad player, and what makes this uninterpretable, honestly, is everybody's on methotrexate in the background. 50% are on steroids. As David said, steroids didn't matter, but everybody's on methotrexate. There are 2 drugs in rheumatology that clearly blunt humoral and even cellular responses, and it's rituximab and methotrexate. Not so clear that JAK inhibitors do this. 2 or 3 years ago, there was a study on Tofacitinib with 40 patients, Kalmark et al., and they showed that 4 out of the 40 had no response while on Tofacitinib and while getting the shingles vaccine. So, and there are other studies looking at JAK inhibitors and pneumococcal responses. Generally looks pretty good. But the bad player here, and why we only have 88% responses humorally, and that's still being a little bit lower than normal people, not immunosuppressed people, and 66% cell-mediated responses. I personally think all that's driven by the methotrexate background. And you wouldn't know because we don't have a control. But nonetheless, we want a study like this that helps us knowing what to do, as Dr. Chan says, knowing whether we need to stop or hold or what to do. And the author, Dr. Kevin Winthrop, said, we need to do this again, this time with controls and not with just with an UPA only arm, at least, to know what, again, how to apply this data to clinical practice. So interesting. John, you must have seen something interesting at the meeting.
I saw several very interesting things, but the presentation that intrigued me the most was the APIPPRA presentation. Andy Cope, on the first full day of the meeting, presented the APIPPRA study on behalf of his co-investigators in the UK and the Netherlands. We all know that the STOP RA, Kevin Dean's prevention study, which looked at patients at risk for rheumatoid arthritis, enrolled patients who were anti-CCP antibody positive and gave them a year of hydroxychloroquine, and the study was stopped prematurely because of a lack of benefit. The APIPPRA study was another prevention study, but it picked a different population. In this study, patients were enrolled who had anti-CCP antibodies, but they were also required to have arthralgia. So these are patients with a little bit more advanced disease. And they were treated with abatacept, a T-cell co-stimulation inhibitor, as opposed to hydroxychloroquine. So abatacept affects cellular immunity. And this study was a positive study. So they were treated with abatacept, 125 milligrams subcutaneously weekly for a year, 52 weeks, or with placebo. And then they were followed for another year. And the patients who were treated with abatacept had a significantly lower occurrence of rheumatoid arthritis than the control group. And the separation was even more pronounced when they looked at patients with an expanded autoantibody profile with more autoantibodies to citrullenated peptides and also rheumatoid factor, suggesting that there's a population of patients with arthralgia who have a relatively mature immune response, and those patients are most susceptible to abatacept, to co-stimulation inhibition, and preventing the development of rheumatoid arthritis. So this study showed that, first of all, abatacept may be an effective drug, and that the window of time in which to intervene may be narrower than we thought, that we shouldn't be going to health fairs and looking for anybody who's CCP positive and treating them with something, but maybe waiting for patients to develop arthralgias and following their immune response, looking at the extent of their immune response and picking those patients who are potentially most susceptible to prevention with abatacept. The other interesting point here was that those patients with arthralgia had improvement in patient-reported outcomes with abatacept therapy. So there was a benefit to abatacept in the patients with arthralgia. Now, we're not going to treat patients with arthralgia with abatacept for no other reason, but if it's effective in preventing progression to rheumatoid arthritis and has a therapeutic benefit during that first year of therapy, it's a win-win situation. So this is a fascinating, positive study, and I think perhaps the most important prevention study so far.
It certainly was positive, at least with the end point of being the delay in the onset of disease. As John said, during the blinded portion, when everybody was either on placebo or abatacept, it was 6% versus 29%. Another year off of all therapy for both groups, it was like 27 versus 32%. So the numbers came closer together. But then, as John points out, the more seropositive you are, the more autoantibodies you had, the more those lines stayed separate. So it at least delayed it. In a subset, it might have prevented it. And the question is, will we in fact use this? And do we have enough evidence? We failed with methotrexate in prompt and treat earlier, at least as far as the primary endpoints. And then it looks like the abatacept trials at both our ARIA we covered last year, and then now this one, these are encouraging. And the question is, would you give your mother or mother-in-law, who has arthralgias and CCP, would you give her abatacept? And I think that remains to be seen, but this is, at least there's some consistency in results in the 3 abatacept trials that are out there. So,
well, the big challenge in the United States is going to be getting coverage for it. The pharmacy benefit managers are probably very unlikely to cover abatacept in patients with arthralgia based on these studies, although the studies to me are very convincing. I'm looking forward to the publication.
Yeah, it will be. So let's get into a round of quickies. My quickie comes from the Mayo Clinic and Croson et al., which looked at, I think it was poster POS 0319 on steroid use in 2 different eras. One era beginning in 1999 for 9 years, second era beginning in 2009 for 9 years. And they showed that in these 2 eras, steroid use didn't go down. 65% and 71% started treatment with the initiation of steroids. both groups, both eras, they lowered their steroid use over time, but unfortunately, at the end of 6 months and beyond, 30% remained on steroids. So the point being that in a more modern era with more therapies and whatnot, we should be using less steroids, and we're not. And more worrisome was the subtext that elderly patients were more likely to start steroids in both eras, and they're also more likely to not stop the steroids. Unfortunately, elderly, as you would imagine, and as shown in the paper, in the poster, had more comorbidities and less background DMARD therapies, as has been seen in other elderly. So again, it's a reminder study that we should do better than we are currently doing with steroids. And again, I'm jumping up and down about this, saying don't prescribe steroids unless it comes with an expiration date. And otherwise, patients just linger on steroids and the consequences of that. Okay, what would be your quickies? Let's begin and go back to Antoni, if you have a sort of a quick one.
Thanks very much. I love posters. I'm great to have all these posters back at the meeting. I was interested in from the Germans Rabbit Registry poster 0174, and this was a study looking at rheumatoid patients with interstitial lung disease and looking at all-cause death. And they looked at people who were treated with DMARDs, biologics, and those who weren't. And interestingly, if the patients who were treated with biologics, the survival was much better than compared to those who weren't treated. So the mortality was 2.8 times higher in the non-treated group versus the treated group. So we tend to perhaps shy away from using some of these drugs in patients with interstitial lung disease, but increasingly at this meeting, we're seeing that methotrexate and these biologics have a protective effect in this group of patients in terms of all-cause mortality. So it kind of really helps seal that we should be treating these patients, aggressively.
So what therapies was this being compared to? So I assume that they're not all rituximab, but it's what was what
it's
were they
a mixture. So they had abatacept, rituximab, tocilizumab, and TNF, and they looked across the board, and the comparator was TNF as the baseline. And what they found is that there was some interesting choices. So they were going for in TNF, the people who had TNF were generally people who had a slightly higher risk, and so they were going for that group. And then the others, the IL-6 was used in the younger group. And then they looked at these different groups and then looked at the all-cause mortality, and found that those who had treated had a better survival rate.
So David, what do you do in patients RA with ILD? Does that color your therapy? Are you more likely to give them more aggressive therapy, or are you not yet convinced by the data?
Well, I think that, the fundamentals are that you've got to try and treat the underlying disease. But having said that, I think we obviously saw data from those combined Scandinavian registries that got presented on the first day in the oral abstracts, looking at interstitial lung disease as a consequence of methotrexate, and then as looking at biologic DMARDs, and we didn't see any association between, and they looked at RA and PSA patients. We didn't see any association with methotrexate and chronic interstitial lung disease. We didn't see any signals for any of the other biologic DMARDs. So I think that gives me some reassurance regarding that as well. But in terms of actually dealing with the underlying kind of RA-ILD progression, ultimately every single study that we've really kind of used to interrogate this is about disease control, and that's what we've got to go for.
You know, I have to. I agree with Antoni's sort of takeaway on this, that and what David just said, and that I too would endorse this. But to understand it, I would point to John Kay convincing me to invite Dr. Michael Brenner from Harvard to lecture at RheumNow Live on the role of the fibroblast in RA pathogenesis and outcome. It's an unbelievable lecture. It's the one thing we're not treating. It's one of the reasons why we don't see a lot of movement with some of our best therapies on something like ILD, where it's a fibrotic condition, not necessarily, probably driven to some extent by inflammation. But at that point, there comes a point when inflammation is no longer important and the fibrosis continues. So I would just encourage people to look at the video that's on the website and on the YouTube channel from Dr. Michael Brenner and RheumNow Live. It does help explain a lot what goes on in rheumatoid arthritis. and what the unmet need is. John, your impression of this research?
Yeah, and I agree, and I would treat the disease more aggressively just to control disease. But as you point out with Mike Brenner's talk about the role of the fibroblast, there are different subsets of rheumatoid arthritis which have different cell types that are dominant. And we treat macrophage dominant with TNF inhibitors and lymphocyte dominant, maybe with T cell co-stimulation and inhibitors, B cell dominant with rituximab. But the fibroblast dominant disease needs to be addressed differently. And Cospitalis is really addressing this by doing biopsies and subsetting patients and directing treatment according to the histopathology. And I think ultimately that's going to be the way we're going in terms of treatment of these diseases.
Yeah. David, you have another one?
Just a quick one. I think telling us something that we probably already knew. And sometimes it's nice to be told that what we know already makes sense. This is from the oral abstract sessions looking at methotrexate in men who are trying to conceive, men with rheumatoid arthritis trying to conceive. We've been telling men in that situation that it's been fine to continue taking on methotrexate, that paternal methotrexate. It's not something we should be worrying about during conception. And there's some nice rationale that came through, which has now been published in the Annals of Rheumatic Diseases, looking at FPGS as an enzyme. That's an enzyme that's responsible for methotrexate polyglutamate metabolism. It's lacking in spermatozoa, and that really explains why we end up with polyglutamate 1 and less of the later polyglutamates, which are responsible for the actions that we see in other places that's beneficial for rheumatoid arthritis, but not so much so for sperm health. So I think that gives us a really clear rationale for why we make the recommendations that we do, and I think we can keep on reassuring our male rheumatoid arthritis patients who are trying to conceive.
And that the bottom line is that they should be stopping methotrexate, or is it okay to continue?
You continue away, just as we have with recommendations. I mean, would you recommend otherwise?
No. And the current ACR guidelines say that males don't need to stop their therapy when it comes to conceiving, or with the maybe exception of cyclophosphamide. Everything else is okay to continue, and because there's no reported benefits. But this particular abstract looked at it more from a mechanistic standpoint, and then the fact that it agrees, I think, is encouraging.
Absolutely.
David, I'm sorry, John, your last one.
So the last one is one that hit the jackpot. This was a presentation on the second day of the meeting. And there were 3 presentations in the oral session on rheumatoid arthritis that dealt with safety or lack thereof of JAK inhibitors. And all 3 presentations basically debunked the randomized controlled trial oral surveillance, which showed that there was not non-inferiority in terms of major adverse cardiovascular events or malignancy. The JAK POT study was a compilation of 14 registries from across Europe and also including Turkey and Quebec, Canada. And they looked at patients who were starting JAK inhibitors, TNF inhibitors, or biologic DMARDs with non-TNF modes of action. And they looked at the incidence of major adverse cardiovascular events, strokes, myocardial infarctions, and transient ischemic attacks. And they looked at all patients with the referent group being the TNF inhibitors, and they found that there was a numerically lower incidence of major adverse cardiovascular events with JAK inhibitors and not much difference with other mechanisms of action, but the 95% confidence intervals crossed unity, so these were not significant differences. So for all patients, they found that JAK inhibitors or biologics with non-TNF mechanisms of action were no greater in terms of the risk of major adverse cardiovascular events. And then, like everybody who does these kinds of registry studies or claims database studies, they replicate the inclusion criteria of oral surveillance. Patients who are 50 years of age or older with at least one cardiovascular risk factor. And what they found here was that, again, the JAK inhibitors were numerically lower in terms of the incidence rate for major adverse cardiovascular events, as were in this case the other mechanisms of action. But again, the 95% confidence intervals crossed unity. So there was no statistically significant difference in the incidence rate of major cardiovascular events major adverse cardiovascular events with JAK inhibitors or other mechanisms of action. So in the United States, we're faced with boxed warnings on all the JAK inhibitors, but clinical experience in what's so-called real-world settings seems to debunk the gold standard of a randomized prospective controlled trial, oral surveillance. So it's looking as if JAK inhibitors may be less dangerous than they're purported to be by the regulators.
Yeah, I have a contrary view, and not surprising, right? And obviously, these are efforts based on registries, long-term extensions, large data collections that try to, as you say, debunk or apologize for the oral surveillance study based with really, really large numbers. And actually, in this particular, the JAK POT study, which is a total of 20 registries, they only reported, I think, 14 or 15 from the meeting. The problem, the problem was highlighted when you looked at the numbers. The numbers were like over 30,000 patients and over 54,000 courses of drug, but the actual event rates in the three different groups, TNF, JAKs, and then MOAs, was 30 to 80 events. And it was incredibly low. So I actually looked up the oral surveillance numbers, and the event rate is roughly 1 per 100 patient years of the 4,500 patients in oral surveillance. The rates in this study were 1 to 2 per 1,000 patient years. And so when I asked the author about this, he did a lot of hemming and hawing and basically said, you know, it's the problem of registries. You know, there's incomplete reporting, and how it's reported in Quebec and how it's reported in Turkey is different than how it's reported in Finland, and they have no uniformity, and often it's free text. And so these efforts that try hard to justify our continued use of JAK inhibitors, which I'm thoroughly in favor of, never quite meet the mark of the double-blind randomized controlled trial. And I think it's the fact that a lot of people, we don't like the backlash on this, the restrictions on this, because, you know, the fact is that the data applies to over 65 smokers with an MI, and that makes up like an incredible minority of my patients who I'm putting on my JAK inhibitor. But the majority of my patients are dealing with the new rules for JAK inhibition. So we're going to see a lot of these studies, and I like it if they can make me feel better about myself. I just can't overcome the superiority of the oral surveillance.
Well, I agree that there are limitations with registry studies, as you point out, but the STAR RA study, which was a claims database study, also showed that the risk of major adverse cardiovascular events was not increased with JAK inhibitors in the replicate group for the oral surveillance study. And claims data are a bit more comprehensive in that they're picking up diagnostic codes for cardiovascular events as well as rheumatoid arthritis. There's always the chance of misclassification. But
yeah, one of the, and I think we're going to play volleyball on this one, in that all these studies never attempt to replicate truly all the enrollment characteristics, including disease activity, including the background therapies. They can get the age right and the cardiovascular risk factor right, but the rest we've got to go on faith. And again, I use that STAR RA study all the time when trying to talk about whether these drugs are safe or not. But the problem is we're going to see a lot of these studies, and I'm afraid of a false sense of security, and I'm going to have to live with, I mean, in the UK, they have rules that NICE came out with this year about the same thing, a little bit different than the FDA. I'm sure in Australia they have, and New Zealand, they have their own set of rules that, limit these drugs. But it's anyway, other comments about this study?
Well, I think even with STAR RA, while it wasn't statistically significant, the point estimate was for JAK inhibitors versus TNF inhibitors was with the duplicate cohort was 1.24. And so I think it's hard to completely exonerate it on the basis of that. And I think we're going to talk about real world data. I mean, once again, just to play a bit of devil's advocate, the EMA have moved on the basis of unpublished real-world data regarding baricitinib and the concerns regarding that, and MACE that they see in those patients. So I think that ultimately we will have to try. I mean, we would love to wait and see how things go with the baricitinib post-marketing requirement randomized control trial, and I think that will tell us a lot about whether this is a class effect or not. But in the meantime, it's not unreasonable that we proceed with some caution, and it's hard to completely exonerate things on the basis of the real-world data we have, with, I will say as well, limited risk windows. That's the other bit I'd argue. Really, when a lot of these patients have got relatively short risk windows, we might not necessarily expect that to be sufficient exposure to develop the cancers and the major adverse cardiovascular events that we're concerned about. So I can see both sides of the argument.
So, even though I presented the JAK POT study in a positive light, the point that Jack makes about not having disease activity information. Disease activity plays a major role in the development of these comorbidities, and certainly lymphoma and cardiovascular adverse events are much more common with persistent chronic inflammation. And registries are never going to reliably get disease activity information, and certainly claims databases lack that completely. So again, even though this is interesting and a great subject to prompt discussion, we still need to exercise caution when prescribing JAK inhibitors.
I want to pass on one thing I learned back in 2003 while serving on the FDA advisory committee that evaluated the 3 COX-2 inhibitors. And we had 3 days of hearings, and the data presentations were overwhelming. A lot of it trying to justify whether there was a serious real COX-2 cardiovascular risk was registry data and large data sets, just like we're talking about now. I was blown away by presentations by epidemiologists, but specifically by Milton Packer, who's big in the cardiology world as a sort of trials guy, epidemiology guy. And he said something which I subsequently found to be true in many ways. And that is that large data sets, like especially registries, are never proof of principle. At best, they are hypothesis generating that needs to be proven by other methodologies to be truly valid. And otherwise, all we can do is just feel good about what the registry showed us. So with that said, I'll ask Anthony to close with any other comments on this.
I think they were done at different times, so these registries were recorded pre oral surveillance. So so there should be.
Well, leave it to Dr. Chan to get it right, and I forgot that point. So the point that Dr. Chan is making is all the data that's being reported in JAK POT was actually accrued prior to the announcement of the oral surveillance study, which, faulted as you may, whatever problems they had were problems across the board, and the relative differences between the treatment groups still remain the same, meaning that there was no difference. So maybe the story is right. Thank you, Anthony, for bringing that up. That's very important. All right, folks, thanks for this great review of RA topics at EULAR 2023. Tomorrow night, same time, same bat channel, we're going to discuss the hot topics on lupus. Tune in then. Thank you, guys.
Thanks.
Thanks, Jack.
Thank
Great
you.
seeing everyone.